afternoon and a very warm welcome to everyone. On behalf of Penang Institute, I would like to thank you for taking out your time to joining us on this afternoon's webinar on COVID-19, achieving herd immunity and the way forward. My name is Puyi and I'm your moderator for this afternoon section. Now, we know that Malaysia's COVID-19 vaccination rate has been very impressive. More than 88% of our adult population has been fully vaccinated. And our health DG has indicated that interstate traveling is to be expected in the next few days. Well, all else being equal, it does seems like we are all on our way out of the woods and we are slowly regaining some semblance of normalcy. Yet, what remains constant is that we have to continue to live with COVID 19. The threat of virus mutation persists, and of course, we can't go out without a mask nowadays. So, then are we truly safe despite being vaccinated? Is vaccine indeed the silver bullet in this protracted war against COVID 19? And what does it mean for us to live with a COVID 19 endemic? So, joining us this afternoon to answer some of these pressing questions are two experts. First, I'm pleased to introduce to you our first speaker, Dato Dr. Amar-Singh. Dr. Amar has served in the civil service for 35 years. He was formerly the head of the Paediatric department at Ipoh Hospital and also the head of Clinical Research Center at Perak. Dr. Amar is also an honorary senior fellow at the Galen Center for Health and Social Policy. So this afternoon, Dr. Amar will be discussing on the challenges of herd immunity, the threat of virus mutation, as well as how then should we live with the virus. Allow me to introduce our second speaker. So our second speaker for this afternoon's webinar is Dr. Azrul Khalib, the founder and CEO of the Galen Center for Health and Social Policy. Now, Azrul has worked as a development and programs policy specialist for more than 20 years. He is also the co-founder of the Code Blue Health News website and a co-presenter with BFM 89.9's Health and Living, where he discusses health policy. This afternoon, Azrul will be discussing on the strengths and weaknesses of our health policy and areas that can be improved for future pandemics. Now, just for housekeeping matters, for our audience who are tuning in today, you may post your questions on the comment section on Facebook. We will collect all your questions and we will answer it in the later part of this webinar. So now, without further ado, I would like to invite our first speaker, Dr. Amar, to take over. Dr. Amar, the floor is yours.
Thank you very much, Pui, and thank you to the Penang Institute for this kind invitation. I'm delighted to be speaking here with Azrul. And thank you to Lokman and the others who are in the background assisting us. Allow me to share some slides, share my screen here so that we could cover more ground. Okay, yep. All right. Pui, you can see that screen? Yep, okay. All right, so I'm going to talk about what Pui said about our challenges and the way forward. And I'd like to start off by saying that I speak to you from the First Nation of the Orang Asli people of Malaysia, in whose land we live. I always want to acknowledge these people who were here long before any of us came. Now, there's some important caveats about talking about COVID. The problem is that COVID is very fluid and changing rapidly. The information is changing rapidly. So what we may say today may need to be revised tomorrow. So we need to keep looking at the evidence and the science. But I'll try to be as honest to the data and try to tell you as much truth as I know it at the present moment. Okay? I want to start off by cutting out the word herd from this afternoon's title, saying that herd immunity is not possible. Let's first talk about the challenges to immunity and the way forward. I've got a resource online, a folder that you can access. There are lots of files, I think about 16, 17 files there. Some may be of value to you, and the organizers will put this link in the Facebook. You also can scan it from the QR code. And of value to you, perhaps, is looking at the file on ventilation and getting ready and keeping safe. Plus, of course, maybe building an inclusive society in the transition to a post-pandemic Malaysia. Right. I'm going to be covering a quick update on the current COVID situation. I'm going to talk a bit about impact of Delta and are vaccines still working? Do we need boosters? Delta gives us an idea of the future. And then I'm going to talk about possible futures, the challenges of herd immunity, the threat of virus mutation, And I'm going to project some possible futures for you. And finally, how can we live with this virus? So let's talk about firstly a quick update. Now, we've all know our graph. We've gone through different waves in our fifth wave right now, and it was horrible and tremendous to us, and seems to be coming down. But I want to make a point here. Somewhere in the period of August, September, in many different states, and now in the whole country, we stopped testing asymptomatic contacts. We only tested positive contacts. Happened somewhere around here. Some of this decline is due to our decrease in testing. Some of it due to a decrease in this wave. But remember, it's a wave, and there are more waves potentially coming. Okay. So what is our summary of our situation? The Klang Valley is recovering. Everybody can feel that. 6 or 7 states outside the Klang Valley are starting to recover. These are the states that took over after the Klang Valley was recovering, and that's Kedah and Perak. Penang, the worst hit right now. Sabah still very bad. Pahang, Johor, and others. And by mid-October, we are also recovering because vaccination rates are going up. The situation in Sarawak is still uncertain. I'll come and discuss that peculiarly for Sarawak because it gives us an idea of what's happening to the rest of us. And finally, right now, there's a growing outbreak among children, which is of concern to me as a pediatrician. Now, as we look at data, one important caveat right now is don't look at Malaysian data as a whole. You must track your state data. I hope at some time we have district data, and we need this data to understand how to respond in our own region. So we all know this COVID Now site, which is a wonderful site, and you can see this, what I talked about, the Klang Valley coming down in number of cases, and other states also coming down. I think Penang's been one of the slowest to come down. But remember that this drop here, some of this drop here is a change in testing strategy rather than an actual drop in number of cases. All right. So how should we monitor the outbreak? I think it's very important that we as a public or as professionals, that you need to know how to monitor the public. And these are the metrics you could look at. Now, I put these 4 guys up because these are some of our heroes who created this COVID Now website for us, which makes life so much easier now to monitor. We could monitor by cases, but as I said, testing is very different. So this is not a reliable metric. We could use ICU numbers, but there are limitations to that. Deaths, again, some limitations because of brought-in deaths. Long COVID, I'll say a few words about it. We have hardly any data about it. And so the best metric, I think, is new hospital admissions. Not just hospital admissions, but new hospital admissions. So I like to say, move away from looking at new cases to new hospital admissions, especially in a highly vaccinated population like ours. Because new cases will happen. We expect a lot of them to still happen, especially in vaccinated people. But what we want to look at is severity, and that is given by new hospital admissions. I was just talking to the COVID Now team in the last 48 hours saying, can we move hospital admissions to new hospital admissions? And they were very kind. They've actually done that immediately. So now you notice that in the last 24 hours, they've changed hospital admissions to daily hospital admissions. So you can now track how many new people are getting admitted every day. And this is the total utilization as well. So we have these good figures to look at. So look at how many people are being admitted every day, because one of the best metrics to look at for monitoring the pandemic. Why not ICUs? Well, ICUs depending on how many beds you have. When ICU beds are full, then you're not there anymore, and that figure is of no value. So the Klang Valley, many of the states outside the Klang Valley, that data was almost no value. I estimate from the data that we could see at the height of our pandemic that only 25% of people got into a real ICU, another 25% got into a repurposed ICU, the rest was scattered all over, and some not even sent through because they were perhaps too old or they decided not to offer them any ventilation. So ICU doesn't give you a real idea of severity. Hospital admissions, a better idea. Now, I want to mention a word about long COVID, and I hope all of you know enough about long COVID right now. This is one metric that we should try to monitor. This tells us how important COVID is. Yes, deaths are important, but one of the major concerns of all of us as doctors is long COVID, which affects 10 to 30% of people. Nobody's really sure. The real figure is probably 20, 30%. And it's a long-term persistent damage to you where you got brain fog, you can't think properly, you can't sleep properly, you're anxious and depressed, you got fatigue, and some people are permanently damaged. Their heart, lung, and other organs are damaged, and they experience the symptoms for long term. It affects young people, it affects people with mild infections, and also affects children as well. So think about long COVID, and long term, I hope we can make this metric as one more that we can monitor. So what's going to happen to you if you're unvaccinated right now? If anybody listening is unvaccinated, for 100 people unvaccinated, 8 to 10 will become severe. Half of those end up in ICU, and 1% will die. Okay, and about 10% minimum will get long COVID. Now, remember, these are figures from the Ministry of Health from last year without Delta, in the best of situations where we had enough ICU beds to accommodate everybody. This is not true if in the current situation or in a situation where there are not enough ICU beds, or not true if you're an older person, not true if you've got comorbids. All these variables change dramatically. Okay, so I want you to remember these figures as a benchmark, the minimum for unvaccinated individuals. For 100 unvaccinated individuals who get infected, 1 in 10 will be hospitalized. This is current right now, taking into account Delta as well. 1 in 10 will get hospitalized. Half of them end up in ICU. 1 to 2 will die. Why did I put 2 there? Because if ICUs are full, then you're going to higher risk of dying. And at the peak of the Klang Valley pandemic, it was closer to 2. And 2 to 3 out of 10 will get long COVID, possibly even higher if we can get all the data together. So these are the fundamental basic metrics of our situation right now. So what has Delta done to us? And what about vaccines? And we know Delta has moved from the Wuhan to the Delta strain, the strain that started in Wuhan, and Delta is a lot more contagious, a lot more infectious. Okay, we've got very little genome testing, and we need to push this in our country. But right now, Delta is the predominant variant spreading, and it's highly contagious. But is it more severe? Yes, it is more severe. Good data from the UK, Public Health England, one of the best sites to go and look at, and twice as many admissions. Here's data from Florida asking, is Delta more severe? And this is mortality rates. And in Florida, 3+%, 3 times higher rates of deaths in young children and adults due to Delta. So Delta is not the same strain we were looking at. It's a more severe strain. More people will get admitted, and more individuals will die. So the earlier figures I showed you may actually need to be revised upward. Okay. How's our Delta wave? Here's looking at data that the Ministry of Health made available online in a data dump. And you can see that if you look at the number of deaths, you can see that 75+% of all our deaths happened just in July, August, and September. That's a huge volume of deaths. And that's when Delta struck us. Delta struck us about July. And that's when all our deaths went up. You can see that with 8 deaths per hour, 1 in 5 were brought in dead. The ratio changed. Originally, more men than women. Now men and women about the same. Again, Delta has changed this. 1 in 3 are now well people with no comorbidities, no chronic illnesses. 1 in 2 are young people who now die. And the majority, of course, are Malaysian citizens, in case you think this is non-Malaysians. We have no data at all of the people who die after leaving ICU. And I want to say that this death number is not complete. 1 in 10 in the UK die after leaving the ICU. But I suspect in Malaysia, you probably can make it 2 in 10 who die after leaving the ICU. So there are a lot more deaths due to COVID that are unaccounted for here. So this is our concern right now. I show this because you need a person to see. The one on the X-ray on the right is a normal person. The left is a 29-year-old well person who developed COVID and died soon after this X-ray was taken. And COVID is not just a pneumonia. COVID damages your blood vessels in your heart, in your lungs, in your brain, and other organs, and it kills you very rapidly. And we don't know why it kills some people and doesn't kill other people. So let's come to this issue. Do we need a booster? Because of Delta. Before Delta, we were not thinking about this at all. So the important question to ask, is the immunity waning with the vaccination? Or is Delta actually a variant that evades vaccination to some degree? Our problem is that antibodies are no value to look at because we need cellular immunity, and that's hard to test for. So the next best thing is looking at real-world data. And I must say that we are less concerned with you getting infection as we are concerned with you getting severe hospitalization or symptoms. So if you're vaccinated and you get a breakthrough, that's not so bad as if you're getting hospitalization or severe symptoms. So keep an eye on this metric. Okay, here's some data from the Israel, which many people think is having a massive problem and waning immunity. But this is the figure quoted in the press. But if you go to this very interesting site, which looked at the data in more clarity and applied something what is called a Simpson's Paradox to it, which we need to know in research, that if you break up the groups by age, then you find that the vaccine is still working. This is Pfizer here we're talking about, still working very well for hospitalization and for severe illness, still in the 85 to 90%. Here's a nice gentleman, Jonathan Stern from Bristol, who summarized all the available data showing that for mRNA vaccines as Pfizer, that the vaccine efficacy is still working very well for severe disease hospitalization. But if we know that it's not working so well for symptomatic disease. So this is Public Health England showing that before Delta, the vaccine was reasonable for getting infected. Now with Delta, 1 in 3 people are going to have a breakthrough infection. But we still got very, very good vaccine efficacy for hospitalization. Okay. This is just something that just came out this week from Lancet, and I want to concentrate on the purple line. This is people who all experience Delta, and they want to talk about, did they get more and more infections? So you can see their months after vaccination, as they went further and further away from their vaccination doses, more and more people had a breakthrough infection, almost up to the point of 50% there. Earlier in the Public Health England, it was about 30%. So, 1 in 2, 1 in 3 persons are going to get a breakthrough infections. But again, from this same study, the vaccine efficacy against hospital admissions against severe disease was still very, very good. And that's what the place we should keep looking at. So if I summarize that for you, you notice that there are pink slides along the way, which are summary slides in case I'm going too fast with you. For AstraZeneca and Pfizer, the risk of severe disease is reduced 10 times by vaccination, but the risk of infection is only reduced 3 times. So let me put that another way. 1 in 3 of vaccinated people are probably going to get breakthrough and maybe even higher rates, but people who are vaccinated clear the infection faster, have a milder disease, don't go on to hospitalization or death, and they are less contagious. But it doesn't mean that you still don't wear a mask. You still need to wear a mask. So recognize that some of us who are vaccinated are going to get infected, but we're going to get a milder disease than people who are not vaccinated. Now, if you look at data from COVID now, this is also happening. Look at cases by vaccination. As the non-vaccinated cases come down, notice that the vaccinated cases have gone up a little bit. Why? Because there are more vaccinated people. So obviously, breakthrough infections are happening here. Okay. I want to talk about now the difference, summarizing all that I've said just now for Delta, the difference between unvaccinated and vaccinated. Okay. So, for the vaccinated people, 1 to 2, I suspect it's more like 2, will require hospitalization. We have no idea of deaths, and I'll show some Singapore data later, which suggests that deaths are probably 0.1%. But long COVID data from Israel suggests that still about 20% of these people still get long COVID, which is not very exciting. But a study from France showed that they recover very, very much faster than non-vaccinated. So definitely the vaccination has changed the face, especially of hospitalization, of deaths, and perhaps of long COVID. So what about Sinovac? So far, I've been talking largely about Pfizer and AstraZeneca vaccines. UK, Public Health England, a lot of AstraZeneca, Israel, a lot of Pfizer. And pre-Delta, we had very, very good data from Chile showing that Sinovac was an excellent vaccine. But recently, we've noticed that Thai Indonesian governments giving booster doses of mRNA or other vaccines to their health staff because they all had Sinovac and a lot of breakthrough from Sinovac. And I especially look at Sarawak because Sarawak's 80% Sinovac. Let's skip those slides. Okay, so if you look at Sarawak data, where a lot of people have been vaccinated and 80% is almost 80% is Sinovac. If you look at the blue line, we saw in August this rise in cases, and the red line, rise in hospitalization, and the red line, the rise in ICU admissions. And the vast majority, 70% of these are actually vaccinated individuals. So we started to ask ourselves, looking at international data, looking at whatever studies are available for Sinovac, is there a larger breakthrough for Sinovac than there is for Pfizer and AstraZeneca? And we've got this data that recently was published by Ministry of Health. This is the graphic that they put out for public consumption, but this is mixed data, limited value, because it mixed all the vaccines together. But let me look at when they separated the vaccines out. Here's AstraZeneca fully vaccinated. Here's Pfizer fully vaccinated. Here's Sinovac fully vaccinated. And this is prevention of ICU. And you can see the Sinovac prevention against ICU is not as good as the other two. Similarly, protection against death is not as good with Sinovac. So it suggests to me in real world data that perhaps Sinovac is not as effective as the other two in protection against death. I wish there was better data that we could look at. I must say that this data is still mixed data because we haven't divided pre-Delta and post-Delta. And we might see a big difference if we did that. So again, I want to suggest that we keep watching what's happening in Sarawak. watch the ICU numbers, but especially watch the hospitalization, and that will give us an idea. Of course, right now, Sarawak has started booster doses for older individuals and those with comorbids as well, in view of this data. Okay. So do we need boosters? We must keep looking at cellular immunity, not just antibody studies. We expect a breakthrough with Delta, but there's no real evidence from anywhere in the world right now for routine boosters. I must tell you that. Okay, except maybe we need to think harder about Sinovac and get more data there. There is a need for a third dose. This is not a booster. Anybody who's immune compromised, who's got a lower immunity, won't respond well to vaccines, and they should routinely get a third dose. But we know the Ministry of Health has gone ahead, a third dose for immune compromised, boosters for above 60 and frontline workers, and also people in long-term care facilities, and also people previously infected with COVID-19. I want to say that for healthcare workers, one reason they're giving a booster is they can't afford them to take off work if they get a breakthrough infection, and that may be a good reason. Having said that, you must remember vaccine equity, and if we use our boosters extensively, then other nations who don't have enough vaccines, especially Africa, may develop variants which may then come and actually affect us later. Why don't we respond to the vaccine? There's a very small, tiny minority who don't respond because they don't respond. That's their immunity. It happens with all vaccines. Some people have an incomplete response. Those are immune compromised and need a third dose. Many of us respond fully, but there's a Delta breakthrough, as I mentioned. And we don't know whether there's really a true waning of immunity. I'm still not fully convinced about this. Okay. What are our possible futures? First of all, I want to say that let's stop using the word herd immunity concept. It's not a possibility. Once you have breakthroughs with Delta in immunized people, you cannot think about herd immunity. There's also a small proportion of people who are still hesitant to get a vaccine, so they also will get infected. Australia has done very good modeling for us and said 80% of adults is insufficient. A lot of people will still get deaths and long COVID, so they estimate that 90% of the population is required before we can open up. Even then, there'll be a lot of cases of long COVID and fatalities. So we don't think herd immunity anymore in our thinking. Okay. How to predict possible futures for us? They depend on the manufacturers, on our natural infections, on the vaccine protection, on breakthrough, on our social behavior, on new variants, on how much we accept, how much disease burden we accept, and of course, new therapeutic options that appear. Let me predict some futures for you. Currently in Malaysia, this is our situation. Okay. We have a lot of fully vaccinated adults, but there is a core of unvaccinated adults. I do not know how big this is because we don't know our full migrant population. But we have 8 million people who probably got infected. 2.2 known multiplied by 4, 8 million. And we are now vaccinating another 3 million teenagers. We probably will go on to vaccinate our younger primary school children, but we will have another core kids down here who may have difficulty getting vaccinated because they're very young. So we've got pockets of our population who are not vaccinated. Okay, so one thing good about Malaysia is we're not COVID naive like Singapore is. We have a lot of people who had COVID. Okay, our vaccination rates are high, but our problem is our public compliance SOP is very, very mixed. We haven't fixed ventilation. Testing is not widely available due to cost, and our healthcare has not been adequately boosted. I'll leave Azrul to talk a bit more about this. So one possible future is that this line here, this endemic line, but actually what's going to happen is we're going to go up and down. We're going to have a cyclic epidemic curve on top of our endemic curve, and we hope that gradually with time, this is slowly going down. Okay, a lot depends on breakthroughs. A lot depends on size of breakthroughs. A lot depends on what we expect. I say that the what I anticipate and accept is that 20% utilization of the health services by COVID is the maximum burden I can accept. But will it change if we have new variants? I have no idea. So let me show you what may happen next year or in this coming year. Okay, these are assuming 80% of the population and not adults, 80% of the whole population vaccinated and 20% not vaccinated. Assuming a 1 in 3 breakthrough, can you see that we will have 8 million infections next year if all these people are infected as we open up and we move around? Okay. Notice that there are only 6 million infections from the unvaccinated because they are a smaller group of people. But when you took hospitalizations, only 85,000 in hospitalizations from the vaccinated, but a huge 1 to 8,000 hospitalizations from the not vaccinated. I've mixed adults and children given a ballpark figure here. So this will amount to 10% of admissions. So if we have this next year, no new variant, just Delta carrying on like this, the minimum we will have is 10% of our hospital admissions will be used up by COVID next year. Do we accept this? This sounds reasonable, but I'm giving you a very, very minimalistic picture, and the real figure is higher. What's happening elsewhere in terms of the future? Germany, which got a 64% fully vaccinated population, still has restrictions for indoor. They are very, very good with testing. You cannot enter a building unless you're vaccinated, recovered from COVID, or tested, and they're starting to boost older people. But look at the ICU numbers. The ICU numbers are still 1,400. So obviously, they although they've opened up somewhat, they're still having, and they largely use mRNA and adenovirus vaccines. Here's Denmark, completely different. 75% of the population vaccinated. Since September, no restrictions anymore. And the number of COVID patients admitted to ICU actually went up for a while and then has come down. Very, very amazing. And we don't really understand why. They're also not a COVID, naive country. They have had a reasonable amount of COVID spreading. What about Singapore, a country that we look at very hard? Notice that if you look per million people, Singapore has overtaken Malaysia right now in terms of numbers. There are a couple of reasons for that. But they're a highly vaccinated population. A lot of boosters in progress. They've got strong mask mandates. They've got a very disciplined population, but they are COVID naive. They have very little COVID that's spread in their population, unlike us. So they have moved primary schools back online. They've gone back to work from home. They reduced in-diming. And the public are even saying to the government, please put in more restrictions. We're not happy with the limited restrictions in line. So very different from what's happening in Denmark as well. Okay, and I think you should keep looking at Singapore data. It gives us an idea what's going to happen to vaccinated people. Of course, remember they don't use Sinovac. They use predominantly Pfizer. And of the last 28 days of cases, 1.4% require oxygen. It's gone up to 2% at some times, and a very tiny fraction require ICU care. Still more unvaccinated occupy ICU than the vaccinated. So this gives us some idea, as I suggested earlier, what's going to happen to us. China is completely not planning to live with the virus like the rest of us are, and instead they're building huge quarantine facilities, and they plan to quarantine people to come into the country and not get infected with COVID. I'm not sure whether this is actually possible at all. Okay. US, a country which is very mixed and messed up, notice that they've got increasing deaths, and they still not come to any place of settlement at all yet. Okay. I want to say that what's happening right now in Malaysia is we're having a pediatric crisis as society and economy opens up. As we move to an endemic phase, a lot of children are going to get infected, and some of them, 1 in 100 will get hospitalization, 1 in 5,000, 1 in 10,000 will die, and 1 in 10 will get long COVID. And this pandemic is going to last many months. This is not a predicted future. This is a real future because we have difficulty protecting the younger children. Okay. You can see that happening in UK. You can see a huge spike as they open up schools in younger children. And that's going to happen to us if we open up our schools. Okay. Other possible futures that we develop new therapies to COVID, as Merck has shown one right now. I hope this happens. A lot of people are working on this, and this may change our future and give us a brighter future. We may have COVID moving to become milder variants. This is a hope over time, but not a very strong hope, I must tell you. More likely hope is that new vaccine-resistant variants are going to come because there's no global vaccine equity, and we also have zoonotic reservoirs from animals. And we may have to start all over again if this happens. Remember, the Spanish flu is still circulating in the world with new variants. What we really hope for, the biggest hope that we can, is that we work towards a pan-coronavirus that takes care not just of this particular virus, not just of new emerging variants, but of all coronavirus. And this is a plan that many people are working towards, and we hope this is one of the possible futures that we have. I want to say at this point that, all this may be moot while we talk about COVID. The climate emergency is something that may wipe out humanity long before COVID does that to us. Lastly, living with the virus very quickly. Let's skip that. I think there are 3 things that we should do. We need to reduce our viral load. We need to reduce severity and reduce community spread. And you must come with the idea that all of us are going to be exposed or have COVID in the future, even if you're vaccinated, and you need to prepare for this. And there are a couple of 4 things I'd like to say to you. First, masks are here to stay. Wear masks all the time. Wear the best mask possible. Long term, Even after COVID settles a bit more, wear a mask the moment you are unwell and stay away from others, and wear a mask when you are in a crowd. And wear the best mask that you can find, not just a three-ply mask. Okay, a face shield is a good adjunct to add on. The second thing is you need to fix ventilation. There is no return to school or work without fixing ventilation, and we have not done this in Malaysia. We must do this. So work from home as much as possible. Use RTK antigen weekly if you're going to office or school is a good way, and improve your ventilation considerably. Long term, we must work to give staff paid leave whenever they're sick. We don't want them in with us. We must encourage unwell children not to come to school, and we need to renovate and redesign our buildings. I've got lots of ideas about ventilation. I leave you to read them in the document, and we can take them at QA time. But one very useful item is a portable air cleaner, a good one, okay, and a CO2 monitor. And many people are developing a low-cost COSI cube. The third thing is you must have COVID safety bubbles. We need everyone vaccinated. We need to use testing a lot more widely, and we need to have trust. We need to trust that other people are also being safe. And I talk about these trust bubbles. If you're working in office and you're different staff members, you keep your family safe, other people get a family safe, and the office becomes a safe place to work. If you have a larger office, I would suggest fragmenting your office, as we were planned to fragment classrooms in schools from each other, so that if one groups get infected, you don't have to shut down the whole office. Okay? The key areas to worry about is lunch, the toilet, and transport. And these are areas that you need to worry about. Never unmask in a toilet. Don't eat lunch together, because that's when you unmask. And try and actually minimize group transport. Okay? Social dynamics need to change. And I think limit unnecessary social dynamics. Some things that you may consider necessary, I consider unnecessary. There are many other ways to interact socially. And perhaps if you're traveling, do an RTK antigen before you travel. Okay. Long term, I think no travel if you're unwell. We have to change our whole concept of global tourism, and we need to try and keep online interactions for conferences, meetings a lot more than we did before. We haven't addressed our public health system. I'm not going to cover this. I hope that Azrul will talk about this, but we haven't built our public health system adequately. Finally, the last four, get vaccinated. A lot of people are worried about a small, tiny bubble here, which is side effects. I'm worried about this long COVID, worried about collateral deaths. I'm worried about deaths due to COVID, and I'm worried about the impact of COVID on our life. Okay? So the keys as we move forward and live with COVID is wear a mask, wear a good mask, wear a mask all the time, fix your ventilation, improve your ventilation, and monitor your ventilation with a CO2 monitor. Test at work, contact tracing, and isolate if you're positive, and then please vaccinate. Thank you very much for listening to me. Back to you, Pui.
Okay. Thank you, Dr. Amar, for the insightful sharing. Let me just recap a few key points. So, it's important to note that COVID is changing. Herd immunity is no longer possible. And there's a danger that there's a growing outbreak among children. And for most of us who have been vaccinated, it is still important to continue to wear masks and to be safe, because it is still possible that there will be breakthrough infection as well. So, okay, so I shall now invite our second speaker, Dr. Azrul, who will be speaking a little bit more on the health policies. And Azrul, over to you.
Thank you, Pui, and thank you to the Penang Institute for this kind invitation to speak on this topic. And very often it's very hard to follow from an excellent speaker like Dr. Amar, but I will try my best. Before I begin, I would just like to mention that I do apologize for being on an all-male panel. I do think that we need to make a more stronger effort at being inclusive, and certainly we should have more speakers who are women who speak on this topic, because we certainly have quite a few of them in Malaysia. So without further ado, let me just go straight to my presentation, which I will be speaking to you a little bit about this afternoon. And I do wish that we are able to bear in mind some of the points that were made by Dr. Amar earlier and put it within the context of what I will be speaking to you in a short while. Now, my presentation is really talking about how we're getting out of this public health emergency, or very often it seems like we're in a disaster movie, really, and we're asking the question, how is this movie going to end or not? And so I will try to attempt to answer this question, and definitely try to put forward a few issues that are worthy of discussion later on during the Q&A. So the outline will be, first of all, I'm going to be talking about the good, the bad, and the ugly of Malaysia's public health policy response when it comes to the COVID-19 public health emergency. It's based, actually, for those who are much older, on a spaghetti western where you have Clint Eastwood acting as the good. But I think it's better that we examine some of what went right and what went wrong, as well as what could have been improved upon in the response. And later on, I'll be touching on a little bit on COVID-19 becoming endemic. And certainly, Dr. Amar has covered quite a bit on that issue of what does it mean when we're talking about this transition, but also, most importantly, what does it mean to us as people who are going to be living with this virus for many years to come. So I really believe that in order for us to move forward, we really have to take stock and look back at what we've actually done right. And in no way is what I'm going to be presenting this afternoon exhaustive. Certainly, I've tried to, as best as I could, take some of the good examples of each of these areas and try to highlight them for the purpose of this discussion. But certainly the list is quite long when it comes to both, well, not both, but the good, the bad, and the ugly. So I would like to highlight some of these points concerning the good. First of all, when you look at the leadership of the Ministry of Health, certainly when it comes to those who have been at the forefront of the public health response, we certainly have seen, in comparison to many other countries, a very strong, clear, consistent, but most importantly, leadership in the public health response that is trusted by the Malaysian public. And certainly there is very clear examples of how Malaysia's response at the very beginning of the COVID-19 crisis, certainly in the months of February, March, but certainly even in the months before, when Malaysia had started to prepare for the possibility of a global pandemic, there was quite a lot of foresight into thinking of how Malaysia would respond, and certainly was responsible for many of the low cases that we saw in terms of the epidemic at that point of time in Malaysia. And certainly if you look beyond the June-July period, where the issue of vaccines became more and more visible, there was a discussion concerning it, and most importantly, there was a coherent and decisive move to procuring vaccines and certainly securing them for the population of Malaysia, in which we are able to basically say today that we are basically reaching 90% of the adult population have been vaccinated with COVID-19 vaccine. And certainly when we look at this, this is really due to strong leadership that occurred at the very beginning. One of the things that we sometimes take for granted, really, in terms of a public health response, is really the need for clear and coherent public health messaging. And we certainly saw that coming out very well, I would say, from the Ministry of Health, especially in terms of communicating with the public in terms of what needed to be done, what kind of behavioral change that needed to be adopted, and as a result of what was communicated, certainly, the SOPs, the wearing of masks, the social distancing, etc., there was strong public support as a result of it, and the public did respond positively. I know there's been a lot of discussion, last year there was a lot of complaints from the government, especially about how Malaysians were not complying to SOPs. There was a lot of people who were not wearing masks, etc. But when you look within the context of the larger picture, you find that Malaysia's compliance to SOPs was very, very high compared to other countries. In other countries, like what you saw in Australia, what you saw in the UK, in the US, where compliance to what was being imposed was more like around 60, 70%. In Malaysia, definitely at the point of the first MCO, you saw basically around a 94, 96% compliance with SOPs. In fact, this was a key highlight by the Majlis Keselamatan Negara at that point of time, the Security Council, represented by Ismail Sabri at the point of time talking about it, where they were complaining, yet at the same time highlighting that Malaysia had a very high rate of compliance. So, it is really a minority of people who really, at the beginning, who were not really complying with the public health messaging, because essentially, overall, Malaysians were following SOPs. Another thing that really worked in Malaysia's favor really was the strong public health expertise. Malaysia has the benefit of having very experienced, well-prepared and dedicated healthcare professionals who have been working in infectious diseases, communicable diseases, looking at issues of pandemic response. We've had different outbreaks that occurred in Malaysia, Nipah, MERS, H1N1, SARS, and so forth, which has actually informed upon Malaysia's preparedness and resilience towards disease outbreak. And one thing that people probably don't realize is that before Malaysia entered the outbreak phase, really what we saw was Malaysia went into the COVID crisis being the third most well-prepared country in the Asia region, and I think around 18th in the world, based on the Global Health Security Index, which has been put out by the Economist Intelligence Unit, as well as the Johns Hopkins School of Public Health, where Malaysia actually rated higher compared to Singapore when it came to disease preparedness and resilience, certainly when it comes to health security. So Malaysia came into this crisis relatively well prepared. However, it must be stated, though, that this is just really as a result of years of investment in this area. And unfortunately, what we need to be able to do in the future, and certainly what this crisis, and certainly the disruption that the COVID crisis has actually caused, is for us to rethink about how we continue to underfund health. We don't spend enough, and really, this is really due to the sacrifice and hard work of our healthcare professionals, as well as the people of this country being able to work together to actually get to where we are today. And if we had been even the slightest less lucky, we would probably end up like some of the neighbors around this region, which are not as strong in terms of the response, such as Indonesia, Philippines, and certainly in places like India, which are unfortunately having to go with tragedy after tragedy. I want to talk about the bad because it's not well balanced if we just talk about the good. And certainly one of the things that we saw last year was the onset of complacency, which started to appear really, and how Malaysia started looking at countries like New Zealand and Australia and thinking that Malaysia should be able to achieve what those countries have been able to achieve, which is low or zero cases at that point of time in terms of the pandemic. And there was a lot of discussion as to whether or not what we were actually seeing was actually the actual cases that were appearing as opposed to those that were being reported. And certainly what we could actually see from the data that we've been able to gather thus far is that it was very likely that it was very much underreported when this early thinking had been developed, and that there were more cases in the community than what was actually reported. So there was also an issue concerning vaccines. A lot of conservatism, really, with regards to the development of COVID-19 vaccines. The thinking was that it wouldn't be available by end of 2020. So there wasn't a lot of seriousness in terms of trying to procure vaccines earlier on. So we were a little bit behind some countries. There was a lot of suspicion, even amongst health authorities concerning mRNA vaccines. And there was a preference for the inactivated virus model. It was even considered at one point, and has been publicly stated, that perhaps vaccines were not necessary and that we will be able to achieve basically a zero case approach to dealing with the COVID crisis in Malaysia. And that was what was the thinking back then. We also had the unfortunate perception that public health advice was being misused for political agendas. We saw the perhaps premature adjournment of parliamentary sessions that were based on public health advice concerning possibility of COVID cases in Parliament. there was the arbitrary COVID related advisories that were seemingly not necessarily evidence-based. And we saw that in terms of some of the MCO SOPs, even the fact that the Sabah state elections were able to be held, and then later on, there was no real quarantine measure that was put into place by people who had gone there, and resulted in the the second wave of cases later on. Very unfortunate, though, this is, I consider, one of the worst things to have happened is during this public health emergency, is that there have been consistent raids conducted on foreign migrant communities. Now, what even we saw during the first MCO was that the authorities took advantage of the fact that people were sheltering in place, were limiting their movements and so forth, to conduct immigration enforcement raids on foreign migrant communities. And this resulted in a gap in terms of the trust that's needed in order for them to be able to be covered by public health initiatives such as testing, such as community finding cases that are present in the community. And these days, when we talk about is vaccination of those communities. So people were finding that they could be at risk of being detained if they were to go and take advantage of these public health initiatives. So these raids continue until today. In fact, I think there was a raid last week in which migrant communities are consistently having to hide rather than come out and be vaccinated. And one last bit on this particular issue is the fact that perhaps as a result of complacency, that vaccines themselves were not actually even included in the budget 2021 budget, which resulted in Malaysia strangely not having an allocation for the vaccines it needed to procure in 2021, but not covered, not budgeted, and resulting in the allocation coming from the National Reserve, the Kumpulan Wang Amanah Negara. And this really has got to do with the earlier thinking of vaccines in the government. The ugly stuff, which is not great, is, first of all, as we all know, is definitely double standards. There was double standards for pretty much everything when it came down to it. There was a standard for VIPs, personalities, individuals of whom had a certain high profile or connection with the government. And this applied for things like gatherings, weddings, events. Even you can see there that people, even amidst lockdown or restriction of movement, people were able to have makan-makan or meet and greet involving politicians, celebrities. And you found that even ministers themselves were, until today, I would argue, still not observing SOPs, such as wearing masks in Parliament, who themselves were perhaps focal points for the spreading of infection. And that was quite unfortunate because it actually resulted in an erosion of public trust. Definitely, when it came down to it, the ugly also included religious events, congregational prayers. There seemed to be a difference between Muslim and non-Muslim places of worship, bodies, observance concerning adherence to SOPs. It seemed like for the Muslims, there was more latitude, there was more allowances for it. And we saw for Hari Raya, for Ramadan, the whole month of Ramadan and Hari Raya, and then later for Eid al-Adha, that congregational prayers were being allowed to the extent that hundreds of people could be present for prayers, even when there was a huge surge of cases. And you can see there in that graphic there that I've indicated that Masjid Wilayah in the Wilayah Persekutuan area, which had 300 people, were being provided for the opportunity to have Friday prayers and Eid al-Adha prayers as well. Now, if you look at this, and the reason why I wanted to highlight how that one had a real bearing on where we are in the epidemic, so you can see there in terms of the cases that you can actually map them against the surges that occurred, and we see there that the second and third surges are clear, but the fourth surge, which is really the Eid al-Adha point moving on from there, is something that really is as a result of the multiple spread events which resulted in COVID-19 firmly embedded into the community and arguably, I would say, reversing all previously perceived gains. And You can see this in terms of when you compare Ramadan in 2020 and in 2021, where Tarawih prayers were permitted by the government, that there is a comparison in terms of the number of cases that could be seen there. So you can see that for the whole month of Ramadan, cases were steadily on the increase, and this was as a result of arguably Tarawih prayers that were occurring during that period. So I wanted to talk a little bit on COVID-19 becoming endemic, and I know Dr. Amar did speak about that earlier, and I just wanted to mention to all of you in terms of what you can expect in the progress of a pandemic, because there's been discourse after discourse. There's been the use of the word endemic for different contexts, and it seems like people don't really fully understand what does that all mean. So let's look at the progress of a pandemic. What you see, first of all, is what you would want to possibly have, which is total extinction of the pathogen which causes disease. So that the pathogen no longer exists and wiped out totally. And perhaps we don't even know what the pathogen is anymore. And in modern history, there's been no real extinction of any pathogen which causes particular disease. So that one we haven't really seen. Global eradication of disease is something that we have seen for diseases such as smallpox, where there is a concerted effort due to the nature of the disease and also who it affects, which is predominantly children, where there is an effort to want to eradicate. And for many countries which are able to declare themselves free from smallpox, you find it possible to then declare that there's been a global eradication. So in the case of smallpox, essentially aside from small reserves or storage of samples of smallpox in certain high security laboratories around the world, smallpox has largely been eradicated, unless it exists in some remote part of the world which we don't know of, but essentially it has been declared eradicated. What many of the countries are striving to achieve really is local elimination of diseases such as polio, malaria. And in the case of polio, you saw in 2019, I think, the re-emergence of polio in Sabah, where Malaysia had for years been declared polio-free and had been able to eliminate the disease, but the emergence of polio cases in Sabah basically meant that Malaysia no longer qualifies for that status. Malaria is something that Malaysia is very fortunate. We have not seen human malaria cases for the past 2 years, and Malaysia is actually on the cusp of being declared malaria-free by the World Health Organization in that respect. So this is something of a good development for Malaysia when it comes to malaria. And finally, of course, we have surges of diseases which continue to occur. And these surges may be from several cases per day to hundreds of thousands of cases. To give you an idea of what I'm talking about, consider dengue, which is endemic to Malaysia and continues to infect people every day and even cost lives. We have basically 361 cases per 100,000 people in Malaysia. And it's an example of an endemic disease. So I wanted us to bear in mind that if we're talking about COVID-19 becoming endemic, it would look like something what we see today with dengue. So endemic really refers to when the disease is controlled at or below an acceptable level. So the issue here is when it's acceptable, it means that the healthcare system is able to cope, is able to treat, and is able to ensure that people get the necessary care if they're infected with the disease. So the issue of acceptability here is really dependent on the severity of the disease. So you find a situation where there is a higher level of severity, there is lower acceptability. So you have fewer cases, but more action due to it. So because we don't want to see more cases of that particular disease occurring because it's so severe. And this we see from diseases like malaria and maybe in some countries dengue and so forth. But we see in terms of acceptability that the higher severity it is for the disease, the lower acceptability in terms of that disease. However, for those diseases which are of lower severity, you find that society, government, generally the healthcare system has high acceptability, meaning it can cope with the prevalence of that particular disease. And I give you herpes, for example, genital herpes. You can have a situation where a third of the population live with one type of herpes, but because it's not as severe, there is a higher acceptability, and therefore it's something that, even though it's endemic to that population, it is very much considered acceptable at an acceptable level. So here's the thing, and I think Amar has mentioned it just now quite clearly, is that endemic means that it will continue to be there in the population, even in the presence of vaccines. And it continues to be monitored by public health bodies, healthcare professionals, and so forth. And it will always be present in the community for a long time to come. And that's something that we have to consider, especially since we are seeing the use of vaccines in the population, yet we are seeing still that there are breakthrough cases, meaning that people who have been vaccinated are also turning out to be positive for COVID-19, or in many cases that we're starting to see, also perhaps infecting other people, or even being hospitalized, and there have been cases of death even. So the issue here is then going to be something that we have to determine ourselves based on what we know of the disease in Malaysia, what we know of disease in other countries, what is the efficacy level of the vaccines that are being used, and most importantly, I think the question about what are we going to do about breakthrough cases? How are the breakthrough cases that are going to occur going to be acceptable to us? And certainly, what are we going to do about it? And definitely, some of the issues that have been brought forward now include things like booster shots, including third dose, depending on which category of individuals that we're talking about. But really, it does give you an idea of what the future could be. And the future is not going to be herd immunity. That's certainly out of the window, especially with the variants that have emerged. And Delta is only one of the variants that have actually appeared on the scene and to be much more pervasive. It's more virulent and as has been proven, perhaps even more severe. The Delta variant was actually discovered mid last year, but only really became quite a prominent variant within this year. So there could be other variants out there, which means that in the foreseeable future, we are going to perhaps need seasonal booster shots that will require us to be vaccinated continuously, in the same way that we look at the flu shot, where once a year, perhaps you need to be vaccinated against a particular strain or variant of the disease. And definitely what we're seeing around the world today is a variant of COVID-19, which is not the wild type that we first saw in Wuhan. And today, Delta seems to be the dominant variant, but not too long ago, in the UK, for example, you saw the Kent variant, which was dominant and then taken over by other variants, including Delta. So we are going to have to adapt. And most importantly, I think this is where more investment is needed in public health, is that our healthcare system also needs to be adaptable, it needs to be flexible, and most importantly, is able to get the necessary people who are specialized, who are able to provide the necessary support for a population that's going to be facing endemic of COVID-19 in the future. But today we're talking about COVID-19, but the reality really is, for many of the people who have been working on infectious diseases today, is really we're thinking about how COVID-19 is the dress rehearsal for the next pandemic. If you can believe it, we're already thinking about the next pandemic beyond COVID-19. So this could very well be a sign of things to come, because I think Amar mentioned just now about climate change. Climate change could actually result in perhaps more diseases suddenly emerging from the countryside or from even places which have been untouched due to it being frozen or some other. So there is going to be a need for a lot of countries to be more resilient and more prepared when it comes to diseases. So I will stop there, and I thank you for your attention and for listening to my presentation. I'm happy to take questions in the discussion which will follow. Thank you so much.
All right. Thank you, Azrul, for your sharing. That's really insightful. And if there's one thing that keep echoing is that there's no herd immunity. What is even more scary is that this is the dress rehearsal for the next pandemic. So we are looking ahead for more bad news. Okay, so let's take a look at some of our questions from our audience. First, we have Sil and Lim. When she asks, are there any data on efficacy for Sinovac? I think Dr. Rama has mentioned a little in his presentation. Perhaps you might want to elaborate a little bit more on that.
Thanks, Suen Lim. I could have shown a bit more. I skipped some slides. There is some data from Thailand, a good study showing antibody drops over time with Sinovac more than with the other vaccines. But as I said, that's not a good marker. We need cellular immunity, and that's from real-world data. I think some of the best data now is coming out of Sarawak. UNIMAS is doing a study which involves genomes and looking at all those who are admitted and especially vaccine breakthroughs. I think that data will give us an answer. Probably this month or next month we'll get the data. Meanwhile, the data I showed to you from our own vaccine study by Ministry of Health shows the Sinovac is not on par with Pfizer and AstraZeneca when it comes to hospitalization and ICU beds, ICU admissions. So I think we need to look at that. I think it's a marvelous vaccine. If you've got no vaccine, take Sinovac. I would say that it's a great vaccine, but it doesn't seem to protect with Delta only. I'm talking about Delta. It doesn't seem to protect as well as the other vaccines at the present moment. But definitely, there's a poverty of data on Sinovac, which is very sad. We need more data.
Okay. Thank you, Dr. Rahman. And we have...
Yes, Amar will do Pui, huh?
From Beeling. So this is Beeling calling you, Dr. Rahman. Besides Sarawak, the local data analysis also have to consider we put older people in phase 2 on Sinovac for its lesser side effect at that point. Also, perhaps Pfizer stocks are not enough. Yeah, we must follow up because breakthrough in countries only using mRNA is not low too. So it's a comment, but is there anything you would like to respond
Yes,
to?
I'd like to clarify what Biling is saying. Now, breakthroughs are going to happen with every vaccine, full stop. That's a fact. What degree of breakthrough, I'm not sure. Right now, I would say 1 in 3, but my real personal belief is maybe everybody will get a breakthrough with time, okay? With every vaccine. So I think that's happening all over the world, they're recognizing. But a breakthrough is not where you should look at. You should look at, do you end up hospitalized or do you end up with ICU admission? And currently, the breakthrough that happens with AstraZeneca and Pfizer, the protectivity long-term still looks very good. Sinovac, not bad, but not as good as the other two. So I think look at the end point of that breakthrough, whether it ends up with ICU admission or hospitalization. And for that, we need to keep tracking data. I recommend that you look at Public Health England. They publish data every week, which is excellent. Now, why are we using vaccines the way we are? Because it depends what's accessible. As a country, we take what vaccine comes our way. There's a whole shortage in the world. But you can notice that right now, if you go to COVID now, you will see that there's a rise in the amount of Pfizer being used because definitely the country has purchased a lot of Pfizer vaccine, and I think we will see a lot of that. All our boosters will probably be Pfizer as well. That's our recommendation also.
Okay. All right. Then moving on, we have Ahmad Francisco. I hope I'm reading your name correct. Why is the UK, perhaps 55% of the total population has been vaccinated, and USA, I think it's mentioning 53% of the total population has been vaccinated. I think it means a full front economy, but Malaysia, where almost 90% of our population is vaccinated, but we are still not opening our football stadiums, nightclubs, and offices. Azrul, perhaps you might want to respond to that.
Well, I'm all for going to a football stadium, and I'm actually quite envious with the fact that London had its London Marathon just last weekend, and I'm actually wanting to look forward to the day that we can all be together and to be able to gather at these sort of events. But the reality is that we really need to consider what our comfort levels are. And the government is looking at the number of cases, the daily cases, obviously, but also the breakthrough cases, and also what to do about it. And the fact is for Malaysia, we still do not see the kind of performance in the vaccines of the vaccinated population as what we see in other countries like the UK, US. And I think Amar has shared some of the data just now. And the thing is that the government and public health authorities are not yet comfortable about providing that kind of liberties that we see in those countries. Because what could happen is, and we're going to see it soon, yeah, now that there's going to be this interstate travel, there's going to be like a reduction of all these restrictions. There could be a massive surge in the number of cases that are going to be reported. Now, as was mentioned, it's not so much the fact that people are getting infected or breakthrough cases that we're concerned about, it's the fact that could be more people who are going to be hospitalized, falling seriously ill, and dying as a result of it. And that's going to be a price that's going to have to be paid, and it will happen. This is the thing. This, with the announcement that's going to be coming in the next couple of days, we're told, there will be these surges of cases. We saw that in Langkawi just recently with this bubble that they created. So we need to make sure that the public health system is able to take in those cases and to be able to provide them with the kind of treatment that they need. And when the public health authorities are comfortable, then they will allow it to happen. But the fact is, and this we need to be prepared, is that it will happen regardless. And the fact is, Malaysia, as mentioned, we have 90% of the adult population already been vaccinated, but we're still seeing a lot more cases. And as Amar has shared, we are going to perhaps even need to be prepared for an outbreak amongst a much more younger population, which has not been as prominent as has been over the past 18 months or so.
Pui, if I could chip in a little bit to
Yes, yeah.
amplify some things. If you look at COVID in children, right now 35 to 40% of all our infections are children, by the way, not adults. And they're not spared. If you talk to my pediatric colleagues working in hospital, they're seeing a lot of very sick children on ventilator, some small babies. So that's a price is Azrul want to pay. I want to say that the response from European and US countries is very different from Asian countries. And when you think through this, one reason I would say is our health systems are not the same. You can't compare the UK health system to Malaysia. In UK, for months now, almost a year, everybody had access to 2 COVID tests a week if you wanted to. You could do 2 COVID tests a week. We can't. We have no access like that. That changes the dynamics of who's going to get infected, how much spread you have. I'm also saying that we must stop looking at adult vaccination rates, look at total community vaccination rates, and Malaysia is only about 63, 64% right now. And look at the whole metrics. Deaths in US are higher than Malaysia per population, but they seem to accept that. But there are people, healthcare professionals, very, very angry in the US with the government for what's happening right now. Their pediatric ICUs are full. Their adult ICUs are still choked. So they're not doing as well as we like to think, despite opening up and dropping their mask mandates here and there. And if you look at Singapore very carefully, their death rates are reaching UK death rates right now, something that we never expected them to see, despite the extremely high vaccination rates. So what burden of disease are we willing to accept? Do we boost our health services adequately? There. Must remember the West is very experienced with or used to having influenza deaths. They expect that every year. So they look at this as, okay, it's like an influenza death. We expect some people to die. I don't think we are tolerant of that. How many children would you allow to die? How many of your grandfather, grandmother, uncle, auntie would you allow to die? I think we are very less tolerant of that volume of deaths. Right now, already more than 80, 90 children in Malaysia have died, and hundreds have been in ICU. So that kind of metric is not coming out. I've asked COVID now to give us more data that we can track children, and that might actually change the perception of people on how much we want to open up. So like Azrul, I'm very worried, Mamarentas Negeri, what the impact will be on old people, those with chronic diseases, and on children, even if they are vaccinated.
Okay. All right. So moving on, we have Khairuddin Hussain, who his question is to Azrul. Have you gone through data comparing COVID-19 deaths against other causes and see if there is an actual increase in total deaths over the time since it first appeared in Malaysia? Yeah.
So this is a great question. We have been trying to answer this question since last year, but the reality is that it's complicated by quite a number of issues. One of which is the data is not as forthcoming from the Ministry of Health on this issue, because we need to be able to compare it against a similar time frame on the excess death to know that there's been excess death due to COVID-19. But also there is the problem of classification of deaths, even when the person is COVID related. There is basically deaths caused by COVID-19 or death with COVID, and the person may have underlying conditions such as non-communicable diseases like cancer, cardiovascular disease, chronic kidney disease, and so forth. So there's a lot of factors that come into play before you can declare that there's been excess deaths due to COVID-19. I know in other countries, like Indonesia, for example, it's fairly straightforward, but we're actually much more stringent in that definition. So it's much more later that we're going to be able to look and conclude whether or not there's been excess deaths. I can say from basically the rough data that's available to us that there seems to be excess deaths. And I include not just COVID, but also the other diseases that cause death within the period, and basically compare it against a similar time frame of last year and the year before. But if you're talking about just about COVID, we don't know yet whether or not there's been excess deaths due to COVID specifically. So we are likely to see this data towards the end of the year. So Khairuddin, if you ask me this question again in December or November, I'm going to be able to answer you, because that's when the data is going to be much more transparent. And definitely with the new Minister of Health that's come in, was promised that there'll be more transparency and more sharing of data. We're going to be able to answer some of these more, data-centered questions as compared to before. But what we're actually really worried about, and I want to just take advantage of this question to say, what we're worried about is the non-COVID-19 related diseases that have caused death, and the mortality that has increased due to people dying due to cancer, chronic kidney disease, even diabetes, hypertension, stroke, etc., which have been exacerbated due to the COVID-19 response, due to the MCO, the CMCO, the restriction, the movement restriction, the 10-kilometer restriction for movement. All these things have had a health outcome. And that is what we're worried about right now, because I can tell you that the number is possibly larger than the deaths caused by COVID. But we're going to wait until November before we're going to be able to answer that question properly. Over to you, P.
Puyi, can I chip in a bit more and say, it's very muddy what Azrul said, because some areas deaths have come down. We are less on the road now. We all got stuck in the house. So road deaths, which are about 8,000 plus a year, crash completely in the country. Similarly, because of our limited social contact, dengue has crashed as well. So dengue deaths came down. We wear masks, so other respiratory infections have come down. But as Azrul pointed out, collateral morbidity and mortality from people who needed healthcare and couldn't get ICU bed, that's the one that we should look at. So it's not so straightforward. We should look at trends from the previous years and this year, and then try and tease out what is really happening.
Okay, all right. And yes, it's also from Khairudi Hussain, who has a question for Amar. How safe are the COVID-19 vaccines for children, and is the safety more to do with physiology of young age?
Thanks, Khairudi. That's a topic on many people's minds, and I've done 2 or 3 talks recently in the last couple of weeks on children and vaccines, going through all the data. And I'm quite fussy because these are children, and if you asked me 3 months ago, I would say, I'm doubtful, I'm not sure I want to vaccinate children. But watching what's happening with Delta, not just overseas, but in Malaysia, listening to the trauma the children have suffered in terms of long COVID, in terms of ICU admissions, in terms of deaths, I have swung around to say that the morbidity from the vaccine, the damage from the vaccine is far less than the damage from COVID to children in Malaysia, not just thinking of someone overseas. So children seem to have, I would say, a higher specific side effects than adults in some ways. When you think of myocarditis from Pfizer, children have higher rates than adults. If you think of the bleed in the brain, I suspect also, although we have no data just yet, with the AstraZeneca one, the younger you go, the higher the risk of a bleed in the brain. And with Sinovac, the data is very, very limited for what the safety profile in children. I'm sure, again, the nerve damage with Sinovac will happen more commonly in children than it happens with adults. So having said all that, the risk from COVID is always far greater. If I just take one risk, for example, the myocarditis from Pfizer, if you get COVID, your risk of myocarditis is 1 in 3,000. If you take the vaccine, it's 1 in 20,000. And that COVID myocarditis is not the same as the vaccine myocarditis. It's a nasty one. It damages your heart considerably, whereas the myocarditis from the vaccine is a mild one, and the vast majority of people recover well. So yes, Caroline, I'm prepared to give my own children. I think almost all the pediatricians I know in the country have vaccinated their children as quickly as possible because they're actually seeing the damage that it happens to children. So there are going to be some children who will be damaged by the vaccine, but the vast majority are going to be protected by the vaccine.
Okay. And we have a follow-up question from Beeling for Dr. Amar. In your opinion, Sinovac data, as you mentioned, is not a very good quality for kids. How do you think MOH should review them, especially below 12 in the next round?
Azrul, please chip in also because you may know some things. Now, first of all, I want to say that, China is a fussy country. We may think otherwise about Chinese goods, but they're not going to vaccinate their population with a vaccine they don't have good data for. Just they don't publish the data. That's all. That's the problem with us. They don't publish the data. They have phase 2 trials on Sinovac in children, but they don't have phase 3 trials, which we're looking for. And most important, they haven't published for us what we need, which is side effects from Sinovac for children, which I'm looking for. So they have gone down to vaccinate down to age 3 in China. Children, and some other countries are also vaccinating down to age 3 with Sinovac or Sinopharm. So I believe that our MPRA, our drug control authority in Malaysia, is a very fussy drug control authority. They have been offered documents from the company. More data has been offered to them, perhaps non-published data, I suspect. I'm not party to those documents. I hope that actually, usually they can't make these documents public, but I wish we could. Then we would see the better safety profile from Sinovac for their children. My concern is efficacy. I suspect Sinovac is just as safe as the other vaccines, but with Delta, is Sinovac going to be a vaccine that works just as well as the others for severe breakthrough infection? And that data I don't have access to. Now, I don't think anybody in the world has got. As I said, it's going to come out from our own country rather than from other countries.
Is there anything you want to add? Azrul, just now, Amar say that you probably have something to add on this.
Well, only just to support what was said. Malaysia's National Pharmaceutical Regulatory Agency is one of the best in this region. It's been recognized. And as mentioned, one of the most fussiest. People complain about them all the time because it takes them, there's so many criteria. People are looking at more than what the dossier provides. And you can bet that there are stringent criteria that needs to be met before they sign off on it. But having said that, though, I do agree that there is a sort of a desert when it comes to Sinovac data. And right now, even when we're talking about heterologous vaccination, where you're using, a booster that is not of the original. So say you've been vaccinated with Sinovac and your booster is going to be, say, mRNA vaccine. There's no data that has been provided. There's no data also for homologous, in fact, even if it's with the same vaccine. So we do hope that there'll be more data forthcoming when it comes to Sinovac, because arguably Sinovac today is one of the more prevalent vaccines in the world, in many African countries, in Asia, and definitely in China, where that is pretty much one of the main vaccines. So there should be a wealth of data, in fact, a better understanding of even the disease as a result of it. And we're just hoping for that data to come out soon, because I can bet you that it will inform on us how we respond in the future about this particular disease, and how whether or not we're going to need subsequent boosters, what kind of boosters, who should get them, is it everyone or is it certain people and so forth. So I think because it's inactivated virus, there's a lot to learn from that model. The mRNA vaccines are very exciting, very sexy stuff. I'm very positive about it being used for other diseases, like HIV and cancer even, mRNA vaccines. But at the end of the day, the inactivated virus model is going to be one of the more common models that's being used for diseases such as this one, and we need to learn what Sinovac has to be able to show, with their deployment of this vaccine.
Well, I do have a slightly different question. Like, I mean, with schools are opening and all that, and as you know, the tourism bubble is opening, people are moving in and out. So, like, and we know, as what you both speakers have said earlier, that the children will be at higher risk. So, moving on, like, as you know, as the schools open, do you think it is wise to put the children back to school, and or should they continue to learn at home? And we know that children attention span is not all that high. So what's your take on that?
I'll go first, Azrul, and please tambah. I think that we need to fix schools. If we don't fix schools, it's not safe to send children back. What I mean by fix schools, we need to fix ventilation in every class. And that requires the air in that classroom must be exchanged 5 times per hour. The other criteria from NOSH, but that's basically the simplest one you can think. That entire air in that class must move over 5 times an hour. A lot of people are looking at UVC, but I think UVC is an adjunct, not the primary tool. The primary tool is that you bring fresh air in and you remove air out. And so the air cleaning systems are what many people are talking about. And I think they're cheap ones. I know there are engineers in Malaysia who are building the COSIQ for classrooms, but they're not on a commercial, large scale. And I think we should work with our parent-teacher associations and get this done. Every classroom should have a device that sucks in air, filters it through a filter, HEPA filter, and then sucks out, brings out clean air. And you need to monitor this with a CO2 monitor, because that will tell you that whether your air is stagnant or not. Of course, the other things like putting a ventilation fan into the classroom, suck air out, or a fan at the window, things like that. So that's the first step. You got to fix the ventilation. Second step is make sure the children's masks are good. And I worry about the portion all the time. I know there are poor adults that I know who use the same mask for a couple of days, and that's not really healthy at all. I think we need to work as a school, and again, parent teachers working with the school to see who needs more masks and making available. And improving the quality of that mask, depending on what the child can cope with, not just a simple 3-ply mask, but maybe not entire or a cloth mask on top. And the third one, I would say, is test everybody. UK has been doing it twice a week, every 4 days. I suggest we do at least once a week. And that means working with the people who produce tests to bring it really, really cheap, and perhaps government subsidized and funded, or partly parent-teacher association funded, to bring it so that every child who goes to school, we can then know. The fourth one is keeping them in bubbles, as I suggested earlier. So only one class goes down so we can continue with schooling. I think if we do some of those things, underpinning all this is the school working very closely with the parents, not independently of. Right now, that is not relationship is not really there. I think if we do this, we can open schools. My personal opinion, Puyi, is don't send them back to school. Let's see the data from Pfizer coming out this month. FDA already received it. Let's consider vaccinating all our adolescents, which we're finishing very quickly, probably in 2 months. Same time, let's embark on vaccinating the 7 to 11-year-olds, another big cohort. And then we push our testing to the younger ones. Then we can save more money that way. Okay, so probably open school about February when everybody is vaccinated. The 0 to 5, 0 to 6 we have not done, and we fix the kindergartens for their testing strategy, and then we can don't need so much money there that way. Just some thoughts only.
Okay. How about Azrul?
Well, I'm not going to touch it from the public health perspective because Amar has done such a great job on it, and I'm always amazed at the kind of devices that are possible for improved ventilation in our schools. And all I could think about was when I went to school, it was just like open windows, big fan, and I'm wondering where's the problem with the ventilation. But obviously there is a problem. But I just wanted to say here, and this is probably very little to do with public health, but really in terms of the education aspect. And I'm just cognizant of the fact that Malaysian kids have not been in school for, I think, around 51 weeks, of in-person schooling. Yeah? And there has been this emphasis for online schooling since last year's MCO all the way up to today. And the expectation is that it works. And we know it doesn't. And the Ministry of Education's own study, the Ministry of Education's own study has proven that 40% of students in this country do not have or do not possess the digital devices that are needed for the purposes of online learning, which means I don't know how they survived this past 18 months, and whether they're using smartphones or parents' smartphone or whatever. The fact is that people are being left behind. Kids are being left behind in school. So in one sense, I'm very torn when it comes to this question about kids in school, because I see it as necessary to get them back in school so that they can catch up. There's a lot of people who say, yes, they can catch up. They're young people, they're kids. Of course, they can catch up. But I've seen so many cases, especially from less privileged neighborhoods, communities, where even a month worth of schooling is too long. And we are talking about 51 weeks of missed in-person learning. People have lost the ability to read. I kid you not, there was a report last year. So we have to balance it now with the possibility of infection within the classroom. And the issue goes back to what was mentioned by Amar. Are we worried that kids will get infected, or are we concerned that the kids could infect other people, that they would be infected, but they're okay, they look fine, they're asymptomatic, they recover, but they could be infecting other people, teachers, their grandparents at home or their parents at home, and so forth. So there's a lot of variables that are being discussed right now when it comes to the safety of classrooms, but also the safety of the kids themselves and how they interact with the environment. So it's not an easy question to answer whether or not to get kids back in school. It's just that rather than say no, we actually have to do what Amar is saying, is to make it yes, but we work to make sure that it's as safe as we can possibly make it, and not use no as the easy way out and say, no, you can't go to school. We can't do that. We have to, how can we make sure that kids are safe to go back to school? That's how we should approach the problem. Because right now, the public health approach has been, unfortunately, no. And that may have worked before last year, but we have to move away from that and answer the difficult questions with increased investment in some of the stuff that Amar has showed in his presentation earlier. I don't know where to get those though, Amar. I've been trying to find some of that stuff, but definitely we need those air purifiers. It can be a struggle, especially when we're looking at reopening classrooms, and each of those classrooms have to have those.
So I want to echo what Azrul said. We want to get children back to school. We need to. UNICEF study showed 1 in 5 children now does not want to go back to school. Doesn't plan to go back to school, especially from inner city, and that is extremely worrying. But we want to do it safely, and we want to do it proactively rather than just say go back to school and then let it get fixed by itself.
Let them float.
Yep.
All right, just one last question. This is from Khairudi Hussain as well. The question is for Azrul. Isn't categorizing vaccinated and unvaccinated people in terms of limiting travel, human activities, be it at school, workplace, or commercial outlets, going to create a segregated society, something that we are trying to avoid, looking at how our political situation is at the moment? Wow, that's a lot in my question.
Well, never mind the political situation. I look at it in terms of social justice, right? And in terms of whether or not it has any benefit in terms of health outcomes. And the reality is that the kind of restrictions, limitations that are being put into place does have benefit in terms of ensuring that people are able to be protected, people are able to be entering safe spaces where maybe in those places they're not wearing masks, for example. I wouldn't necessarily agree with that, but you have meetings, some other people are all vaccinated, and there is a sense of safety and comfort there. And there is always with the fact that there are going to be people who cannot be vaccinated due to medical reasons, and those people exist. And here's the problem. Here's the thing. What is happening today is arguably going to create class discrimination. There are going to be problems. One of the things that I have been quite upset about is the possibility of people being denied essential services on the basis of them not being vaccinated. Like they're needing to enter a government office in order to access welfare services, for example, get aid or humanitarian aid, and then they're told, please show me your vaccination status or your MySejahtera, and the person doesn't have a smartphone, can't afford a smartphone, can't afford the data plan or whatever, and they produce a card, and then the person says, I don't accept a card, I only accept MySejahtera. So because you don't have MySejahtera, you cannot enter the building. So even if that person is vaccinated, the person is being denied services. Now, people who are unvaccinated for whatever reason, and we have to remember, in Malaysia, it is voluntary. People are being told that it is still voluntary. You should have the right to say yes or no, even though it is very much encouraged. But what we need to look at, and I cannot emphasize this enough, is to insert compassion in the way that we look at these issues. Rights, human rights, but also social justice. We have to make sure that we are able to cater for those who are being excluded and not to victimize them. In this case, we don't know why they're not being vaccinated or are not vaccinated, and it's not for us to decide. But I'm worried right now that there is going to be discrimination, that there is going to be what Khairuddin mentioned, a segregated society, but also that we are not kind to each other, that we look down upon people who are not vaccinated and think less of them. And I worry for that, because it means that the society is going to be less kind and more judgmental and less room for tolerance, but also we're not helping people to perhaps persuade them to get vaccinated, because that's the hardest thing in public health, persuading people to adopt behavior, change behavior, or in this case, take a vaccine. And you have to make sure they make informed decisions, which means they have to be educated, they have to be given the information and then decide for themselves. The shortcut is always to make it a requirement, compulsory, mandatory, a mandate. But for certain people, they may decide that, I don't need to be vaccinated. And we have to understand why. We can't close the door and say we shouldn't allow them in. We should be able to understand why they're not getting vaccinated. So this is going to be one of those ethical dilemmas that we're going to be facing. This is not new. Yeah, we've actually faced these dilemmas when we were facing things like measles outbreaks due to anti-vaxxer or vaccine hesitant communities concerning the MMR vaccine. Even mumps outbreaks were occurring in Putrajaya of all places. So these are issues that we need to ask ourselves. Should we then prevent people from unvaccinated children from going to school where everybody else is vaccinated? Things like that. So we need to discuss these issues and we need to decide what do we want. I have no easy answer for you, and I have a feeling that we need some soul searching, because I think we're very harsh and very uncompassionate on some of these issues, and we need to be able to do better. Be kind is going to be the what I would say.
Okay, be kind. Okay, we're actually running out of time. But before I close this section, I just want to ask our two speakers, is there any just one last reminder or just one last point that you want to press into to our audience? Amar, perhaps you first.
It's very difficult to compress into one way. I would say keep an eye, read the data, watch what's happening. This is an evolving pandemic. It's not static. And so I believe that we need to be able to read the evidence, to discern what's the right thing to do and support each other. I think that's the way we're going to move forward.
Okay. And Azrul?
My message would be similar. I mean, our understanding of the disease and the virus changes quite frequently, and we saw that happening last year to quite a large extent because it's a new pathogen that we're trying to understand. And as a result, we, as members of the public, and perhaps people working in the healthcare sector as well, we have to adopt an open mind at the new data that comes in and be willing to change when things require us to change. I think sometimes the public has been very harsh on, say, health authorities when they get accused of being of a U-turn lah, flip-flop lah, or one year. But that's good. It shows that we can change, and the fact is we're changing and we're being guided by the science and evidence, and we need that because the data is going to show us how we need to change, where we need to go, and most importantly, how to prepare ourselves for what's going to happen next. And I would hate to think that people will just stick to one particular decision and be, excuse the expression, pig-headed about it because they don't want to be seen as wrong or flip-flopping. So it's good that we are changing according to the needs, but I think it's good that we're being guided and driven by the evidence and science.
All right. All right. On that note, I just want to thank both our speakers for sharing some very insightful and informative messages for us on how to move on. To live with this COVID-19, we have to be discerning, to keep an eye on what's going to happen next, to be able to adapt to the changes, and most importantly, to be kind, to be supportive to the people around us. So I would also like to take this opportunity to thank all our audience who are tuning in today. So on that note, thank you for your time. Good day. Thank you. Goodbye.
Bye-bye.